Awesome. Thank you so much. Appreciate you guys tuning in. I'm just coming from my office here. It's been a late day and still here grinding. And you guys are still grinding too. So appreciate you guys tuning in. I'm going to go through some slides, pretty casual. And then, like we said, if there's questions at the end, we'll answer some questions. So appreciate your attendance. Well, the topic today is why DIO. And DIO is the name of this implant company. Everyone calls it DIO. It's actually DIO, D-I-O. And I've been using them for the past 4 or 5 years. I've been really impressed with them. So I'm excited to share some of my experience with them and what makes them kind of unique and different. Here's my background. So I run Whitecap Institute located in Utah. At Whitecap, we're a teaching facility for implantology. We're also a dental clinic where we teach or treat patients nonstop. And what I've loved about my journey with implantology is working with other professionals and finding ways to help them increase their implant game so they're more confident, more comfortable, more productive within their office. And so groups like this come through our facility every month, and we help train them and teach them. And part of our curriculum has always been focused on teaching them best principles with best products, best materials. And it's been really cool the last 3 or 4 years to help explain the digital world of implantology to our doctors. And no one does it better than DIO. So I'm excited that you're getting to hear this because I think it can up your game just like it has hundreds and hundreds of doctors that I've been able to rub shoulders with the last couple of years. To start off, though, I want to bring to your attention a book called Bring Them Back Alive. Frank Buck wrote this. He's an exotic animal trapper. And in one of the chapters, he talks about this coconut trap where he puts sweet scented rice into this coconut, ties the coconut to a tree or a stake in the ground, makes a hole in the coconut just big enough for the open hand of the monkey to go in. But as it grabs that pile of rice, it gets stuck because the fist is bigger than the open hand. What I like about this analogy, sometimes us as dentists, we are monkeys. We might get our hand into some clinical workflow or some clinical paradigm of thinking, and we trap ourselves. We don't get ourselves out. And so my invitation for you, if you feel like maybe you're stubborn or stuck in some of your implant ways, I want you to have an open mind. I want you to embrace that there might be some way to let go of what you're doing to embrace a different world. I don't want you trapped. And as I talk about digital workflows, if you're an implantologist that's been doing it a different way for years or decades, that can be a sweet scented rice trap, I'll call it. Or if you're an implantologist or a dentist rather that wants to get into implantology but haven't been there yet, then other dental modalities might be impinging you from getting into the implant world. I want you to let go of that too. I want you to embrace the implant world. And so my invitation as we get started is let's let our hands free. Let's not hang on to any old habits. Let's let go of our comfort zone. Let's embrace something new and different because that's what you're about to be exposed to with what we're talking about. And this shouldn't be new to anyone, right? Like the world is taking over or being taken over by technology. You know, I don't turn up the air conditioner or the heater in my house except by my cell phone these days. Crazy. When you go to a hotel, I don't open up the room anymore with a card. I do it from my phone. These crazy Teslas and all these cool electronic cars are doing really fancy things. And even scuba diving, if you're a diver, a lot of that's done by computer these days. And so the point is technology is all over. It's a new day. It's a new age. And sometimes us dentists are slow to adopt. We're slow to pivot. And I want us to embrace it. You know, if the dang hotel room door lock is ran with technology today from a smartphone, I think our dental offices and especially our dental surgeries should follow a similar methodology. So let me give you my why for a minute before I jump into DIO. When I talk about digital workflows, there's 4 main areas that I think are key. Number 1, it's an improvement for the patient. The procedure is improved, meaning the process of accomplishing an implant in the jawbone. The outcomes are better. And then what I call the restorative opportunity. So the patients who experienced both freehand surgery and computer-guided surgery they expressed that they had a better experience when guided surgery was used. And so that's really important when we're building our reputation, building our practice, building a community outreach to our patients. We want to make sure that we're handcrafting surgical experiences so it's a better, more enjoyable experience. And I've noticed this with my own patients that have commented, but there's even been research on it here, like you see in the survey that was done, that computer-guided surgery is a more pleasant, more enjoyable experience for our patients. And so that right there is reason enough to embrace technology, but it goes on even more. The procedure. So for me, the procedure itself is less stressful, takes less time, is less invasive, therefore it heals quicker, therefore I have decreased postoperative infections that show up. This for me is a game changer. Now it's all about the patient, but these things help the patient because if the clinician is less stressed, they're able to be more dynamic within their surgical approach. If it doesn't take as long, that's better for a patient. If it's not as invasive, that's better for a patient. So I love that technology makes these things better for our patients. The outcome. Now, I tease that these are my first 3 implants I ever placed. That's a joke. They are not. But I found these online. I don't know their backstory, but the point is patients are paying a premium for dental implant services because it is a wonderful service. It is the closest thing we can do to mimic a natural tooth. They deserve the best, and outcomes need to be above par. They need to be amazing. They need to be as good and as predictable as possible. And obviously these 3 examples missed the mark. And so if we can embrace digital technology, which results in a better outcome of the actual surgical experience, meaning the implant is in an ideal position to receive a prosthetic crown that's going to be complementary to occlusion, then we're winning. And that's what technology can do for us. So the outcome is huge. Why I'm big on that is we see complications in implant dentistry. And as Stuart Fromm noted here in his book, it can be said that perhaps the most common type of implant complication is related to a malpositioned implant. So if we can get the implant where it belongs within the osseous and the soft tissue boundaries, then we're going to avoid a lot of complications. So again, the outcome is improved. And then this is what I call the restorative opportunity. And what I mean by that is we today have such accuracy with surgical guides that the implant goes in with such precision, such accuracy, we can make custom abutments and have crowns made, temporary crowns, that go in day of surgery. And they all fit, minor adjustments are needed. And that right there is the restorative opportunity. And we see this on single units like you're seeing here in front of you, or we're seeing that also within full arch and complex cases where we can jump to restoration quicker, more efficiently, because we have a guide that is so accurate, the implant lets everything line up how we want. So those for me are my big 4. The patient has a better experience. The procedure is more enjoyable for me and the patient. The outcome is better, and we have this thing called the restorative opportunity. And I'll show you some cases later that talk about the restorative opportunity and what that kind of means in terms of restoring our patients a little sooner. So with that said, let me share some data that I found really compelling. This is freehand versus guided. Here's the research found right here. And essentially they took 2 surgeons, experienced surgeons. They're placing 200 implants 4 different ways. So a freehand, a pilot drilling only, a full drill guide, but the implant is placed freehand, and then a fully guided technique. So again, freehand surgery. Number 2, they place a guide on, they do a 2 millimeter pilot drill, take the guide off, and then do the rest freehand. Number 3, they will do the entire drilling sequence with an actual guide, and then take the implant or the guide off, and then do the implant freehand, and then fully guided. All of the drilling and the implant placement is all done guided. So those are the 4 types of surgery, and they're going to compare the accuracy of these 4. Now to compare them, this is how they're doing it. Each surgeon is doing a pre-surgical workup on a CT, on a computer, saying, hey, on the computer, based on what I'm seeing, this is where I want the implant. Then they go and do the surgery. A post-op CT is done. They overlay the 2 CTs, and they evaluate where they wanted the implant to be theoretically with where it landed. and they measure the delta. They measure three things: angular deviation, coronal, global deviation, meaning how far is it more buccal than it was planned, and then apical deviation. Here's what's really fascinating to me. Actually, I don't want to jump to that just yet. Let me share something with you. One of the main reasons I got into guided surgery is the ability to avoid my off day. I don't want to be off on my off day. I want to always be more consistent. Like I said, I'm from Utah. Steph Curry right now is playing my Utah Jazz as we speak. That's how much I love you guys. I should be watching the game, but I'm here with you. And the point is, Steph Curry, who's phenomenal at shooting the three ball, probably the best ever, even that guy will hit an air ball from time to time. And we want to avoid the airball moments in our surgery, right? Because even the very best at something can have an off day, a bad day. And I think that's true of us dental surgeons as well. And so look at this data. In the first red circle there, you'll see the average degree that an angle is off. From a freehand standpoint, it was 7 degrees off from their ideal plan. From a pilot guide, just under 6 degrees off. A partial guide, just over 4 degrees. And then fully guided, just 3 degrees. I would say all of those are pretty good, pretty acceptable. But here's what I want to emphasize. On the far right are what I'm calling the airball moments. Look at the max deviation from an angle standpoint of an implant done freehand. 21 degrees off, and these were experienced surgeons placing the implants. Compare the 21 degrees with the 6 degrees, which is the max deviation of a fully guided system in this research with 200 implants being placed. What I love about technology, even if you are quote unquote, like this research, an experienced surgeon, the data would suggest that our max deviation, our airball type moments are mitigated to much smaller incremental discrepancies than the freehand system. 21 degrees. I mean, that's a lot of deviation. And so for me, when I got to data like this, when I started dabbling in some freehand and some guided surgery, that's when I started to realize, you know what? I don't want to have those airball moments. I want to be within a certain measure of off that's predictable, that's easy for me to handle. And that was frankly much, much more manageable with digital workflows and guided surgery. And so this research for me is why today I rarely ever place a freehand implant, just because you don't know when you're going to hit that air ball. Hopefully Steph Curry is hitting a bunch of air balls against my Utah Jazz, but I'm pretty sure he's probably not. But the point is, if we can use a guide, be more predictable, more accurate, why wouldn't we? The patients deserve it. They're paying for a premium product, and the data suggests that we're more predictable with the digital workflow. So with that said, let me jump into digital workflows a little bit. What I love about digital workflows is they give us the entire view. One perspective, like you see here, might make you think one thing, but then when you see the other perspective, you realize, oh, that's what's going on. We don't want to be fooled. We don't want to be confused. We don't want our vision to be blurry because we're only looking from one vantage point. What the digital workflow does for us is forces us to see every aspect of the surgery. What do I mean by that? This implant looks like it's in good jawbone. I see a good buccal plate, a lingual plate. You could certainly go a lot more apical if you wanted. I would say from an osseous standpoint, this looks beautiful. However, that's only one vantage point. If I flip over to the other perspective, which is, oh yeah, a crown goes on top of this implant. Now I begin to say, oh my gosh, I think we have a problem here. So just like the slide before, if we only have one view, we might make a wrong judgment call of what's going on. By looking at both views, we can be thoughtful, making sure that we have not only an implant that fits the osseous boundaries, but also works to hold a crown, which is what the game is all about, right? Holding a crown. So for me, seeing the entire picture is key. So today we can look at preoperative protocols of a tooth reference and a bone reference, sometimes referred to as a digital clone. And the digital clone allows us to plan the case very, very thoughtfully. So we overlay data sets, the CT and an STL, meaning a digital impression. And then with the data sets overlaid, we can plan prosthetic teeth. And then we plan the implants. The implants only exist to serve the prosthetic tooth. So because of that, we want to make sure we know where the prosthetics belong. To put an implant where you think the tooth goes, that'll work a lot of the time, but not all the time. No one knows that better than me. I've done thousands of implants freehand. I've done thousands with guided, and there's a noticeable difference in predictability, in alignment, in congruency of where the implant goes and where the crown goes when I'm following digital workflows. Like that's not even debated. And so I'm a big believer in this principle, because the tooth or the implant is only there to serve the tooth. So we better make sure the tooth and its position, its anatomy is well understood before we start planning implants. So nothing proves it better than this right here. This is one of my favorite things to plan, which is an overdenture type case where I have the patient's exact denture and I'm planning implants to fit within the shell of the denture. There's no surprise if there'll be enough restorative room, let's say for a locator abutment and a housing. There's no surprise if that housing is going to fit within the shell of the denture or if it's going to pop out the buckle because you're way too buccal on your implant. I've read about that, if you know what I mean. And so what I love about a thoughtful plan like this is my stress is decreased, the patient is better served. That's a win-win. And who doesn't love that in business, in surgery, in dentistry? It's a fantastic thing. So that's the digital world. And here's how I like to look at it in a different perspective. I call it the path of least resistance. This is how a lot of dentistry is done. Do a consult, do a procedure, take the impression, and then we design the final restoration. The more thoughtful path, in my opinion, is a consult, gather data, then come up with a restorative design, then plan your surgery around the restorative design. The restorative design is everything. The restorative design is why the patient is coming there. No patient shows up and says, hey, I just want an implant. Don't ever put a tooth on it. They all want the tooth. We need to make sure the implant complements it. Then you go and do your surgery, take an impression, and then we do fine tuning. And that's what I tell my patients. We're going to design the whole case up front. That way there's no surprises. And then once we get to impressions, we're just fine tuning a plan that's already been done. Just like building a house. No one puts up the walls. They frame it all up, and then they decide, I wonder where this roof should go. You know, they figure out the roof before the foundation's even poured. And we need to be more thoughtful, I think, with our plans, with surgery, same thing. So here's the selfish slide now. As I utilize technology, as I utilize digital workflows, for me, my stress decreases. And I want the doctors I teach, the doctors I associate with, to enjoy stress. I don't know if stress-free is possible. I mean, it's dentistry stressful, but I want us to enjoy as stress-free as possible that type of implant dentistry. And in my experience, placing thousands of implants, working with hundreds and hundreds of doctors around the country, the more we use technology, the more we embrace technology and digital workflows, digital planning, guided surgery, the less stressful the world of implantology becomes. Is it still somewhat stressful? Of course. I mean, that is what it is. It's complex stuff, what we're doing, working with a human, doing a surgical and a restorative procedure, like that's complex. Let's not make it more complex than needed. Let's use technology. So with that said, here's the proof. The proof is in the pudding, as they say. This was a class we taught not that long ago where I had 10 doctors in a class. 10 of the doctors, all 10, had never placed an implant before. We planned out a case, we printed surgical guides, and every one of the doctors came up and they all placed an implant. And look how the case turned out. Those are 10 implants placed by 10 brand new doctors that have not brand new doctors, new to implants. And look at the precision of that. And so for me, if I can get an outcome like this, create an enjoyable experience for the surgeons I'm training, the dentist I'm training, and the patient we're treating, again, what more could you want? So how do I do things like this? How is this possible? Well, it's with technology, and specifically, it's with this company I've been working with called DIOnavi. And so Dio, based out of Korea, is a fantastic company. They have been wonderful to work with. They've embraced digital like I've never seen before with implants. So as you can see, I'm pretty pumped and excited about digital implantology. I've always looked for a dental implant partner that could be that partner with me and share the same passion. Dio finally met me. I met my match. They met their match with me. I have really enjoyed their focus on technology because their goal is to create this stress-free or less stress protocol with implantology. Like I said, they're a Korean company. This is their headquarters out in Busan, Korea. I went out there and toured their facility, got to know the ownership of the company, got to understand the business, the nitty gritty. And I was really, really impressed with my experience out there. And so working with them has been really, really exciting, and getting to know them and their brand has been really exciting. They use a word that's kind of interesting. It's called eco-digital. And at first, I totally thought this was marketing hype, just some weird word that, what does that even mean? And the more I've worked with them and got to know them, there's some real relevance to this. And what they mean by this, it's an ecosystem of implantology in a digital format. And so Dio is a little bit different than a lot of implant companies in that they aren't trying to just, to be blunt, they're not trying to just sell you titanium. Right? A lot of implant companies are like, hey, here's our titanium. Our titanium's better than these guys. Our titanium costs less than these guys. Our titanium, blah, blah, blah. What their philosophy is, we want to be an implant solution company, an implant workflow company. We obviously have the titanium is what they're saying, but we also have workflows, we have systems, we have a way in which we're working with the doctor to make implantology more simple and more enjoyable. So for me, if you're looking for just an implant company to buy titanium from, Dio's not your guy. If you're looking for a company that has analyzed implantology inside and out, poured a lot of technology into it, then you would love what you're finding, because that's what Dio is. And so their own, example here, they're an A to Z solution from one company with one vision, with complete control over the entire process and user experience. And as maybe cheesy as that kind of sounds, there's magic to it. There really is. There's a difference when you work with a company that has all in-house solutions, not sending you to 5 different third parties to put their workflow together. And a lot of implant companies, for good or for bad in my opinion, they're just outsourcing all of their solutions. And so that makes it really hard for me as a dentist, because if there's a breakdown in the system and the workflow, who do you go to? And how do you get them to not point their finger at each other? Because they don't control the whole environment. They're just third party and everything. So that's my spiel with the eco digital implant company. That's what Dio is, and they do a really good job with it. So let me introduce you to the implant a little bit more, just so we're clear. The implant itself comes in 2 platform sizes. It has a narrow platform and it has a regular platform. The narrow platform is a 1.7 millimeter hex. It's a 3 diameter and a 3 diameter. So they have a nice 2-piece narrow platform implant. The regular platform is shared between the regular line and the wide line. So it goes from 3/8 diameter all the way up to 7 diameter. And they all share the same 2.5 millimeter hex. And so 2 platform sizes, the narrow platform size, and then the regular platform, which is shared with the wide body and the regular diameters. So they have a good lineup. That's important, obviously, for any implant company. You want to have the right lineup and sizes. They have a micro surface for the upper part of the implant, which we know is better for cortical bone. And then they have a more macro surface for the trabecular bone. And so there's some good research that's better to have more micro threading and micro surfacing on the top of the implant. And that's what you see with the Dio implant. And then if you're looking at their complete lineup, they also have these 1-piece implants in addition. These are called their minis. And they have a crown and bridge application and a 1-piece ball attachment if you're doing a lot of overdentures with the 1-piece. I'm a 2-piece implant guy personally, but clinically there are situations where you might want the 1-piece. Other thing I want to mention, because I think it's really important with the implant, is it has the right connection. And that is so, so important today, is having the right implant connection. It has an 11-degree Morse taper with a hex. And then as you can see in the red lines there, it also has what we call an apical Morse. And so a really good Morse taper, internal conical connection, if you want to call it that, with an anti-rotational hex. And so it has the right connection, which is so important today. So platform switching capable, subcrestally placed implant, really good system there. Now, let me just hit 5 or 6 things that I think make Dio really, really unique, and that might be a reason for you to consider them. So I'm just going to hit the top 5 or 6 things that matter to me. So the fit of the guide. Let me tell you this, their guides fit better than anyone's guides. I've tried several different companies, including printing myself on several different printers with different software. For me, I have never had a guide fit as well as the Dio guide. A lot of them almost snap. You can hear it snap into place. Now, they require really, really high-end diagnostics. So if you're used to doing some kind of cheap diagnostics, I think you'll find that they're a little bit more needy than that. But if you give them really good diagnostics, you will not find a better fitting guide. And I've heard this from dozens and dozens of doctors that do guided surgery across different platforms, and there's something different about it. Why do I make a big deal about that? Well, any thoughtful planning you do online doesn't mean anything if the guide doesn't fit right, or fit with precision, fit with extreme accuracy. And so what you're seeing here is the outline of a tooth, and you're seeing the beautiful, almost marginal type fit, like a crown margin around the contours of that tooth. They really, really are a beautiful fit. And that's the key to good accuracy, is having the guide fit well, part of the key at least. So the other thing I like to mention, when I said they have an A to Z solution all done in-house, they literally have made their own printer. They have their own resins that they have made. And literally they have made them. This is not a printer that they bought and white labeled. This isn't resin they white labeled. They have PhD engineer guys in their facility in Korea. I met them, and their job is to develop resins that work perfect with their software, with their hardware. And so they really have this, we're going to perfect every step of the system to make sure the system works perfectly. And to see an implant company who's trying to sell titanium also develop their own resin, not to sell you, but to just use so the workflow works well. I mean, that's impressive. That's really impressive. To me, it was, at least. So let me talk about drilling protocols for a minute. Something about Dio that was kind of interesting when I first started working with them, their drilling protocol is different, and different in a good way. It seems like a lot of the industry is trying to shift to this, hey, use one drill, less drilling, like just make it almost disrespectful to the anatomy and the biology we're working with, in my opinion. Their drilling protocol is very thoughtful in terms of its biologic approach and its physical approach to making everything nice and accurate. So first off, here's my goals of osteotomy prep. This is what matters to me. I want to be atraumatic to the bone. I don't want to overstress it. I don't want to overheat it. I want good initial stability, and I want the implant in the proper, what we call at Whitecap, the LAD, which is the proper location, the proper angulation, and the proper depth. So that's my goals of osteotomy prep. Now, we also need to think about this with the thought of bone, because anytime we drill, anytime we place an implant, we're putting the implant to two different wild animals. One of it is called cortical bone, the other is trabecular bone. So we need a drilling system that is thoughtful to both cortical and trabecular bone, because we have to treat them with respect, because this is a biologic drilling process. This is not wood shop, right? Wood shop, you can drill till the wood catches on fire. You got to be a little different in the mouth. They're very different. So with that said, let me show you what I'm talking about. Anytime a guide is made from Dio, they will send you in the case paperwork like this that shows you your drilling protocol. The colorful numbers on top, the 20, 27, 38, 40 here at the top, that's your diameter drill. And then the number underneath in black, that is the length drill. What you'll notice is really unique. Well, first off, isn't this awesome? You have a visual representation here of exactly what drill you should use in what sequence. So it's, I hate to say it, it's kind of idiot proof, if you will. They make this very simple, very straightforward, so that when you're looking at a big surgical kit and there's tons of drills and it's maybe a little daunting if you're new to this paper puts you at ease and gives you a systematic approach. A couple things I want to emphasize here, and I don't have tons of time. I need to go through all these a little bit quickly because I could lecture for an hour and a half just on their drilling protocol. But what I like is all of their drills, except a few profile drills, are parallel walled. What I like with that is it's a quick drill through the cortical plate, and then you're through. So you're not constantly, with a tapered drill, constantly pounding the cortical bone at the crest. To me, that is a more atraumatic way of drilling because it's straight through. The other thing I'll highlight, and you notice it here in these 2.7 drills, notice there's 3 lengths used, a 5, an 8.5, and a 10. The stepwise length drilling, to me, provides a much more accurate workflow where we get a more accurate osteotomy. And I've proven that to myself. I've skipped some of those drills thinking it's not necessary and found that the implant wasn't as accurate when I try to put a crown and custom abutment on the same day. Another thing they do is it's slow drilling. 100, I repeat, 100 RPMs is the max drilling speed because we do this with no irrigation if you want, so that we can harvest autogenous bone as we drill. So those are a few of the highlights that I found make a big difference. Let me go into a little bit more detail about that. Here's first off an example of 4 different drilling protocols. Obviously, the paper looks different for every implant size you're placing. But the drill tube, for example, the other thing I'll mention, the 2.0 drills are all drilled with a key or tube like this. So it's a hybrid system. If you know guided surgery, some are keyed and some are keyless or tubed, tubeless. This is a hybrid system. The 2.0 drills use a key. All the other drills after are keyless or tubeless. So you get the accuracy of that pilot drill with the tube and then the convenience of a tubeless system. And so let me talk about this and the accuracy. Here's a competitor, and you'll look at the fit of how these keys work. And there's so much wiggle room in them. I don't even know if they're helping versus the Dio one. So look at the difference when you put a drill in this and you see how much movement there is. You see that there? If you look at that drill apically, it was moving over 1.5 millimeters versus the Dio product. And so just be careful that we don't think all guides and all drills are created equal. I used to think that, where some guys like, oh, I do guided. Oh, I do guided. It's like, no, you're doing something different. Like guided surgery is not the same for everyone. So be aware of that. Here's what I like about starting with the tube to start. If you notice this blue length here, that represents the length of the tube or key. So the initial drill has several millimeters of guidance by the time the drill hits the bone. If you compare that to a keyless system, the initial drills barely have any contact by the time you're hitting the bone. And that can be problematic because maybe you're not as accurate as you'd like to be. So I'm a big fan of starting with the tube with the pilot drill. So the initial osteotomy is perfectly accurate. Otherwise, you're fighting that inaccuracy with every subsequent drill. So here's some math about how it can be a little different. The tube provides more accuracy. So my initial drill is always done with more accuracy because if we start off accurate, we'll end accurate. And so here you see a comparison of the key accuracy versus the non-key accuracy. It's a very tight fit. If you do the math of how much room the surgical guide sleeve has relative to the key, relative to the drill, it's less than 1 degree with Dio. Some systems, to make it ergonomically easy for you, will make those tolerances a lot higher. And it is ergonomically easier, but your osteotomy is not very accurate. And so you're less than a degree movement when all of this is lined up properly, which is what we're going for. We need extreme accuracy to accomplish what we call the restorative opportunity. I'll show you that in just a minute. Here is a slide highlighting the double contact drilling I mentioned. So the 5-0 drill on the right here provides kind of a pilot for the 8-5 drill, and the 8-5 drill kind of a pilot for the 10 drill. This lengthwise drilling provides a more accurate osteotomy. And like I said, I've tested that and found it to be true. So let me show you why this drilling protocol, why the guide fit matters. Check this out. This should blow your mind. I take out a number 8. That might blow your mind. It shouldn't. But we took out the tooth, right? Looks good. We maintain periodontium well. I put on a surgical guide. Look at the fit of my DIO guide. You can tell by looking at all these little windows. Look at the margin. Look at how it's tight relative to the tooth. That's a wonderful fitting guide. I then put an implant in. And what I'm showing here is this silver part lined up with this blue part. That means that my rotational timing of the implant, meaning the hex, is also properly aligned. With that properly aligned, I can actually put in a custom abutment day of surgery, and I can put a crown on the tooth, and the margin fit and the proximal contacts don't even need adjustment. I mean, that should blow your mind. The floss literally snaps on my mesial and distal contact for a crown that was made to fit a margin of a custom abutment for an implant that wasn't even placed yet. It was all done on a computer, theoretically. So that's how accurate my guide is. I've never been able to accomplish this type of accuracy with any other guide system. This was the claim that DIO made to me when they first wanted me to get to know them. And I said, that's impossible. I've tried that a long time. Our lab can't do that. It's not possible. And so some of my first cases were just like this, and I was blown away that things fit because I didn't think that would be possible. So this for me was a big, holy cow, they're doing something different. They're disruptive to this digital workflow because I've never seen accuracy like this before. And so that right there to me is some of the magic of what digital workflows can do and a more accurate system. And this is a more accurate system than anything I've seen. So the drilling protocol, the fit of the guide matter. To do a case like this, you have to have those sort of components, those sort of philosophies to get that done. Another highlight with DIO. Why go with DIO? Well, case in a box. I love this. So if you have a single implant, a case in a box, just like this, the case shows up, your implants, your abutments, your whether it's healing abutment, custom abutment, the guide all comes in one box. So I love that for my singles. Where do I really love that? My full arch. So this is the DIOnavi full arch box. Comes in a big box like this, and you open it up and all of these components are right there in the box. And so if any of you are doing a lot of full arch and you order your implants from this place, your lab stuff from here, your component tree from this part, you know that struggle of kind of juggling all of that. It all comes in one box. And that is a huge, huge relief to me. That makes a big difference for my staff. I'm a big fan of this. This has been a dream of mine to have stuff like this going on, and to have it finally here working is a big deal. So case in a box, that's a huge highlight. Let me talk about a highlight with workflows. Like we talked about, they have some single tooth applications and workflows here with immediate temporization, immediate custom abutments, and temporary crowns. I love that. I want to jump in for time's sake, though, to my full arch workflow. If any of you are doing full arch, you won't find a more efficient system than this. It comes down to these 6 steps, wonderful diagnostics, really thoughtful digital planning, and DIO has a whole planning arm of its company that's part of the DIO family that does all of the planning to help facilitate predictable outcomes. Then doing your implant surgery, hooking up your fixed provisional. The entire restorative process is just a scan of the provisional bridge and then final delivery. For the sake of time, I'm going to go through this very quickly. So when you submit an STL and a DICOM to the lab, they will send back to you online a workup or a plan. And basically you'll see a screenshot like this of every implant that is being proposed. And so here's an implant in number 4 position. It's a 4.5 by 10. And now you see where it is in the pano view, and then the 3 XYZ axis view of the DICOM files. And you get to look at this and approve it, make change request, whatever you want. So the planning is done for you. And that planning includes designing the prosthetics, making sure there's proper prosthetic room, analyzing if bone reduction is needed or not. All of that is done in the planning phase to help complement your own treatment planning. They frankly do a lot of it, but you should be obviously the quarterback on that. So the planning is really, really thoughtful. Having a proper plan, as you know, is always the key to success. And no stone is left unturned with the DIO planning process. From there, you put a guide on, you put your implants in. I'm not going to talk a whole lot about that, just because that's not our topic today. Their workflow is a multi-unit abutment workflow. So the implants will go in, and then you'll place this transmucosal abutment, which brings the margin basically to the gums or just under the gums. And then a temp cylinder is placed. From there, a temporary that has been made from the lab can be used to help pick up the teeth. And so here you're seeing a lab-made temporary with a palatal rest. That palatal rest is there to help maintain vertical dimension, help you seat it properly to get the proper cant and angle and all of that. And so that temporary goes into the mouth. And because of the accuracy of the guide, notice the nice passive fit of those temporary cylinders relative to the prosthetic temporary. That's beautiful. So now all we do from there is we inject a material to pick up the prosthetic. And there's several materials you can do for that. But we pick up the material, and now you see the cylinders have been picked up in the temporary. The temporary has been modified, the pallet has been cut off, and now this is ready to deliver. So the process of full arch and the conversion or temporary phase of full arch is so straightforward today, because the lab plans the implants, the abutments, the cylinders, and the teeth. So things just line up all in one lab, in one facility with one team working on it. Not, again, third parties working on everything. That drives me nuts. I've done that a lot. Now, the beautiful thing is from here, we will use one device and we will do one scan to do our final restoration. So here's how again, I'm going through this super quick. This is a 2-day course I'm doing here in 5 minutes with full arch. But basically, the restorative workflow looks like this. You do a reline impression under the temporary. You then screw in these reverse scan bodies. Then you attach what I call the scanning Lego. And the scanning Lego, the purpose of the scanning Lego is to help the scan data be a little bit more accurate. And so I want you to think of it this way. The distance from number 2 to 15 is a really long distance. But if I can attach something between 2 and 15, like this scanning Lego, I call it, I've decreased that data distance. And we have found in our research that the data is more accurate. So the scanning Lego looks like this, and you literally just push it up into the U shape of whatever arch you're working on, the prosthetic. I just add a bunch of flowable, light cure it, and that acts as a scanning Lego to reinforce accuracy. Again, I could talk on that for a lot longer as well, but really thoughtful, innovative. This is something DIO came up with. So when I talked about solution companies, this is a dental implant company that's helping you scan more accurately so your prosthetic fits more passively. I mean, that's really powerful that an implant company is thinking that far down the workflow. I mean, that's not what they do typically. They just want to sell you titanium. So again, 2 to 15, the data chain is a lot shorter, and it's all circular. And I think that creates more, I don't know, I'm not a physicist, that just creates more accuracy with the data. And I found that they fit a lot better using the scanning Lego. So then you scan the temporary. So again, in review, when it's the whole final impression workflow is a reline impression under your temporary, hook on these reverse scan bodies, attach your scanning Lego, and then outside the mouth, you scan that entire object. Okay. Then take apart all of the stuff you put on put the teeth back in the patient's mouth and just record a bite. So you'll take a buccal bite in 3 spots. And now the lab has all of the data that it needs to make your teeth. Because if you think about it, they've been able now to record where the soft tissue is, where the multi-unit abutments is, where the multi-unit abutments are, where are the natural, not the natural teeth, but where are the teeth? What's the proper bite? What's the shape of the teeth? They see all of that data. And so all you do after you've scanned the teeth like this is you'll take a patient, there's a video of me doing it. I'm going to skip that. You just send that data with a facial profile of the patient, teeth photo, and the lab takes all of that data and they can make whatever changes are needed to get you a more better fitting set of teeth. And so this picture I love here, the bottom right, you kind of see, okay, here's where my teeth were, here's where I want to add it, and any proposed changes are just minor changes from the plan that was done in step 2. So that's the beauty of the plan. In that sequence I showed you, any impression you take following the protocol I just showed you will overlay with the plan the lab already made. And if you modified the bite, if you shaved the teeth, if you added composite to make the teeth look or feel different for the patient, the lab instantly sees that and they can copy it on the plan. And so it's more of a copy, paste, modify it, never starting over from scratch. And that's really, really powerful, because if you've done some of these cases and you start over with a brand new design, it takes forever to get it back from the lab. And it's just the patient's you're never moving in a linear fashion. And so the patient always finds a new gripe because it's a brand new design. And so this is a lot more linear in its focus. From there, you basically decide after you scan it, am I going to do a final or am I going to go temporary? So here you see an example of a new temporary on the left and then a final prosthetic on the right. And so you essentially ask the patient, hey, what sort of changes do we want to make? Do you feel, and then you as the doctor need to decide, do I feel like I can make those changes without too much effort? Or do we need to do a new try-in, a new set of prototypes? And another thing I'll mention with DIO, I try to stay out of the numbers with it, but one thing I really like about full arch and DIO is they give you what's called a bundle fee and a flat rate. So when you tackle a full arch, there's a one price for everything, your implants, your abutments, all of your components, your temporaries, and your final. And so as a clinician, it gives me some clarity of what is this going to cost me so I can price it properly for a patient that's fair to them and fair to the practice. And so that has been the biggest frustration working with doctors is they don't know their hard cost. And by the time they get done, they're like, I don't think I made $1. These costs are transparent and they're upfront. So you know exactly what you're up against for an all-on 4, 5, 6, so on and so forth. Okay, moving on. I got just a few more points I want to bring up, and then I noticed some questions came in and I'll try to answer those. So they also have a thing called surgery simulation. If you're really new to implants and the DIO workflow, you can log on to the website, and I'm just going to skip ahead in this video a little bit. Essentially, they will show you exactly how to follow the sequence and the implants. So if I jump ahead here, let me go right here. Okay, so this little portal you can just access from their website where your cases are submitted. And on the left here are 3 help boxes. Any drill that you're on in this carousel down here, when you click one of these boxes, it'll show you a video of how to use it. So let me play that one. So here's how you use the tissue punch. It literally shows you a video. If I switch drills and push the button, it shows you how to use that drill. And then the bottom one is an information box. Here's everything you could want to know about that drill. So this is like a dynamic, all-encompassing, how the heck do I use it?
Drill.
And so there's even audio.
On 11.
And so it will go through the sequence. I'm not going to go through all of that right now, but you push play and it literally goes through every drill, tells you what line to stop at, what RPM. And if you're new to implants, a lot of doctors like this because you can log in and kind of refresh yourself with how it all works. or read the information boxes, watch a video of how to use that drill. This is a powerful thing. So if I play it for a second, you'll hear it switch to the next drill.
Drill tube. Install.
I'm assuming
Drill.
you guys can hear that.
Initial drill. 2.0 millimeter diameter by 5.0 millimeters at 100 RPM on 11.
I mean, it's just crazy. So that's little surgery simulation is really helpful, and that can make a big difference. One of the last things I'll mention, we're coming up on the last couple of things, is they do have a wonderful website where all of your cases are managed. And so what you're seeing here is a screenshot of my portal. This is obviously from a couple of years ago, if you see the dates. But all of my cases and their status can be accessed from one website. And I could be down in Cabo fishing. I could be over in Whistler skiing, or I could be in my office. You just log into a website and I can approve cases. I can request modifications or just see the status of my cases. So the beautiful thing about the workflow and being digital and online is this is all a website you log on and you can look at it. So it's pretty cool. I like that. Okay, I better hustle. I'm going to keep you guys up too late. I hope the Jazz are winning, by the way. My phone keeps giving me alerts of the Jazz. I can't look though. So these are the pictures that you would see to approve a case. Here's a sinus case, and this is all submitted on the website. Okay, speaking of sinus surgery, they also have a sinus workflow. So here's another YDO. They have a guided surgery sinus workflow that basically takes a guide with stoppers and lets you perfectly drill right to the bottom of the sinus, not worrying about perforating it because it's all measured in the computer world. So after you approach the sinus wall, step one, like I show you here, the next step is to create this opening. And this is done with very slow drilling. This is a 10 RPM drill, believe it or not. And this goes and pushes up into the sinus. And then once you push up into the sinus, hydrostatic pressure is used to elevate the membrane. And then with the membrane elevated, then you pack bone. And so again, it's a solution-based company, but it's safe and predictable. Sinus surgery is, I think it's pretty well understood and done, even with a non-guided application. But with guided surgery, it's even more accurate, even less stressful. And so why not? And then there's a simulation video showing you that as well. And then these are some of the outcomes that you can get with that with guided surgery. Here's a guided sinus lift. That was done crestally, obviously, but good volume, amazing pack. The hydrostatic pressure really elevates the membrane. I could have placed a lot longer implant there, but that's a 10, 15-minute procedure today with guides. And the ambiguity, the stress of it is so much easier to handle because we have a good plan. And if we have a good plan, it turns out really well. And that's the magic, the beauty of all of this. Okay, let me hit my last big topic. This is a huge one. I saved it for last because I think it means a lot, and that is UV activation. Let me play just a little video here. And I hope you can hear this. I don't see why you couldn't. This right here is what's called the UV activator. It is about the size of a coffee machine. So this UV activator, the implant goes into the top of it. This is a special container. And it goes down into the internal parts of this UV activator, and through UV light, the implant is optimized for integration. Pretty cool. This movie is obviously kind of a promotional video. They call it UV photofunctionalization. So if any of you tuned in last night, Professor Ogawa gave a great lecture on this topic of UV activation. So I'm just going to hit on it very briefly and share one clinical case with you. In essence, it is this. The dental implant, as it's exposed to air, ages. And what does that mean? Hydrocarbons build up on the surface of the implant. Those hydrocarbons are hydrophobic, meaning the blood doesn't love it nearly as much. If you can remove the hydrocarbons, in this case, a chair side application. So a minute before, 10 seconds before, whatever, you put the implant in the machine for 20 seconds. You activate it, meaning you use UV light to photo optimize or photo functionalize the implant surface, making it more hydrophilic. The outcome is it will integrate quicker. There's been some research on this, and basically the research was this: if there are hydrocarbons on your implant, it will be more hydrophobic. If it's more hydrophobic, osteoblastic activity on the surface of the implant is decreased. If you're a research geek, take a picture, look it up and read it. Great research. The point is, if we can get hydrocarbons off the surface, make it pure, fresh titanium, it will integrate better with more osteoblastic activity working, which creates a stronger implant sooner. Here's the actual activator. You push a button, turn it on, and then open the door, put the implant in. And like I said, it's a 20-second chair-side application. So you push the button, it comes out, and then you're ready to place, 20 seconds. Here's what we're talking about when I say hydrophilicity. Look at that. So there's two other implants fresh out of the package, and here's an activated implant. Very, very different. Here's another video. Look at this. This video on the bottom is playing the whole time. Look at that droplet, and that's a video still playing. It's a 5-minute video on the bottom. Here's the top video. Is that not crazy? I thought this was like Star Wars fake when I first heard about it, but it's a real thing. And let's talk about what that means, a real thing. Let me skip some of this. We showed you this already. Let me show you a case. So first off, if you're not familiar with ISQ technology, ISQ, implant stability quotient, is a way of measuring the implant. Think of it as like, for just dumbing it down, it's like taking the temperature of meat. So you like put a temp probe in it and you measure the temperature. If I have a number above 70 on this ISQ reader, the Penguin it's called, then the implant's ready to rock and roll. So 70 is passing. I share that with you because you need to understand, how do I know the implant's healed? It's because of ISQ. So here's a case, 52-year-old female, healthy, on no drugs, prescription drugs, no systemic disease, no allergies, everything's healthy, but number 4 needs to come out. Okay, or number 5 here. So we take out number 5, we do a socket preservation. This is in middle of July. I placed the implant 2.5 months later. So a little aggressive, a little sooner, but if you look at the implant placement, the vast majority of the implant is actually in native bone, not my grafted bone. But the implant went in the very end of September. So 2.5 months later, I placed the implant. Pretty aggressive considering it was an extraction site. I get it. My purpose here is try to show you an extreme case and show you what's possible. So I do that, and then get this. On 10/26, this is the ISQ abutment I have screwed in. I do a test, and the results are 7273. Now, is that not crazy? Because if you look at this, I mean, I'm not very many days later. I'm what, a month and a little bit, if that even. So I'm a month of healing, and this implant's ready to go in maxillary bone on a 50-year-old patient in an extracted site. That's crazy. So how is that possible? Well, it's an SLA implant. Talked about that a little bit. And we UV activated the implant. Now, in addition to that, look at the picture. It has a wonderful biotype. And I'm a big believer that thick biotypes heal better. They do better. And so, there are some good things going for this case. But the fact remains, this is a 4-week-old implant in maxillary grafted bone. that's ready to be restored. And it was. I restored it. I took an impression that day. The very next week, I delivered a crown. At week 5, we were done with that case. And she even had her tooth for her daughter's wedding, which is part of the reason why we rushed it, to see if we could get her ready for the wedding. That is really impressive to me. And that has been a game changer for me in terms of, wow, I can really serve my patients better with UV activated implants. And so I'm all about that. Let me really quick just show you a couple of cases. Here's number 10, put a guide on, drill, 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 drill. Look at this, implant goes in, and I put a custom abutment and crown on same day. That's a 10-minute procedure. Marginal fit is good. Proximal contacts are good. Shade is okay. Little blanching on the tissue there. But to put a guide on and have a tooth in 10 minutes, that's remarkable. With a custom abutment, where if the margin looks good, it'll stay in the entire time. Same thing on a number 27, a little messy here. Took number 27 out, put the guide on, drill with the tube initially, right? And then the implant goes in. There's a seating jig, abutment down, crown goes on. I mean, just, and again, proximal contacts fit, margins fit, and the implant wasn't even placed yet. I mean, don't we sometimes take a final impression and we don't even have a good fit to the proximal contacts? So again, let me just end kind of where I started introducing DIO. It's an eco-digital system. It's an ecosystem with digital. We live in a digital world today. That's where the world is. That's where we belong, certainly with surgery. If you're looking for a partner, if you're looking for a new way of doing implantology that is frankly more predictable, easier, less stressful, and a solution, someone who's going to help you accomplish your goals, then I would say DIO's it. And if your hand is stuck in the trap, the coconut trap we talked about at the beginning, then I invite you to let go and try something different. Don't be stuck. Like, the beautiful thing of dentistry is we get to do it however we want. And so don't be stuck in an old way just because it's an old way that's comfortable. Let's be state of the art. Let's be like the hotel where we open our door with our phone, not with a card. Let's do implants with technology, not the old school way, doing it by, just eyeballing it. Because I really don't think we are serving the patient as well as we can, nor is the patient benefiting from the technology that's out there today. So we went through all that extremely quickly. I thank you for your time. That's my personal email if you ever want to reach out. I just want to thank you so much. And I don't know if you want me to go through some of these questions and answer them. Would that be helpful?
Yeah, I think we'll go through the question and answer. But just to let you know, Dr. Riley, the JAST is 5 points ahead. Hey,
that's what I'm talking about.
Yeah.
Okay. Well, we just, let's not even read the questions. Let's go with the game. All right, I'll do the questions. We're just 5 ahead. Man, I'm so happy now. I mean, I'm at work 9 o'clock, but I couldn't be happier.
So
okay.
the first question we have is, are the guides made in South Korea or the Whitecap lab in Utah?
They are made at the Whitecap lab in Utah. It's about 1.5 miles or maybe a mile from my practice here. I'm over there almost weekly working with them. And so they are made in America.
Okay. Another one we have is that, how is the guide more accurate? Is there a special scanner or scanning technique? It looks like all single unit crowns were cemented. Can you make a screw retain crowns as well?
Yes, and let me answer a few of those. So how is the guide more accurate? Well, good diagnostics are going to be key for anyone. The big difference I have found is the software and the printer and the skill of people processing the guide after printing. If you haven't done a lot of printing, you would be disappointed to find out there's a lot of work that goes in after the print is done to make it actually fit properly. And for me, it's a combination and a testament of them owning the whole workflow, right? They have their proprietary software. They have their own printer they've invented. They have their own resin they've invented, and their own people print the guides and process them. These are DIO employees actually printing the guides. And so because that process is all owned by DO mindshare thinking, I just believe it's a better fit. I mean, that's my best example, because there's good printers out there. I know there's good software, but not all of them were built to work perfectly in harmony with each other. And I think that system is the big deal. The second question, part of that was what?
It looks like the single unit crowns were cemented. Can you make the screw retained crowns as well?
Yes, most of those were actually screw retained. There's an access hole on the back. I did cement them in the mouth, but there's an access hole on the back, so you can just unscrew it. So yes, either way you can do it for sure.
Okay, next question. Do you sterilize these implants prior to placement?
I don't personally sterilize them like in an autoclave. They come sterile from DIO. So they're sterile packaged by putting them in the UV light. That's not a sterilizing. It is just an enhancement of the titanium surface. So they are sterile when they come to you in package.
Okay, last question. Guys, if you have other question, you could type it in your Q&A box, or you could actually ask Dr. Riley live if you wanted to talk to him directly. So the next question is, what kind of timeframes are you typically restoring with finer prosthesis? Yeah,
so that's a great question. Obviously, there's a little bit of a patient perspective there, where every patient is a little different with their health history, bone quality, tissue thickness. I would say best case scenario, that 4.5 week is how soon I'm doing some cases. But there's still some today that take 3 to 4 months to heal. So, I mean, if you want the average time, 2 months, maybe 10 weeks. But there's cases I'm getting done in 4 or 5 weeks, which is just, it blows my mind today that we're doing some of that. But yeah, it's possible. But I think 2-3 months, a lot of these cases are ready to go. The days of waiting 6 months, 7 months, 8 months for implants, those are behind us. I don't know if we ever should have waited that long. But with things like UV activation and then things like ISQ technology, we have a way of measuring it to know what's right or wrong. But 2-3 months, I think, is good for almost everything, and sometimes 1.5 months.
Okay. So is there any other questions that you wanted to ask Dr. Riley? Please go ahead. If not, I just wanted to tell you guys that you're going to be seeing Dr. Riley again. He's going to have different seminars coming up starting next year from February up to, I think, August. So we're going to have two in California, one in Costa Mesa, Sacramento, Dallas, Atlanta, New Jersey, and Salt Lake City. So just wait for the information. We'll send you details about the seminars. We're going to have Dr. Riley and Dr. Ogawa as speakers. So if you guys have any other question, if not, we thank you. We thank you everyone for joining us today to our webinar. And thank you, Dr. Riley, for being here. You can go back to your game.
Hey,
more minutes.
well, thank you. I see a couple more questions. Immediate loading or delayed loading. Yeah. Those were all immediate loading that I did. So that was all done immediate. And then are there any specific CTs or digital scanning devices? They all work. Get a good one. I don't want to promote anyone wrongly, but get a new latest model. I think that's important. The technology is changing ever so often, especially the scanning. But I would just get a wonderful quality that gives you a wonderful image. Don't go cheap with those things. Don't go crazy with buying the most expensive thing, but you get what you pay for, I believe, with the technology. And so something that's high quality is helpful. In my office, I use CareStream for my 3D. And then I have a 3Shape, I have a CareStream, and a Medit scanner. And they all work wonderfully.
There's another question, Dr. Riley. What if the ISQ is less than 70?
Let it heal more. Let it cook more. I mean, if you go in at 4 weeks, 5 weeks, 7 weeks, and it's just not strong enough, then give it a little bit more time. And after it has more time, it should heal up. But keep a cover screw on it probably if you just uncovered it. I think that's important. Does UV activation bypass the delayed loading concept? I don't know if it bypasses it, but I do think you just are a lot stronger, a lot quicker. And so I think that window of secondary healing coming in with primary retention, stability decreasing is a shorter window. And so I think immediate loading is a very predictable workflow. Delayed loading, I got no issue with that either. I mean, that's a safe way of going as well. So cool. All right, go Jazz. And
Yeah.
good luck everyone with your practice. Have a great holiday.
Thank you, everyone. We'll see you guys to another webinar.